Hi, good morning, everybody. I'm Vicki Howard. I'm going to just give it about 30 more seconds and then we'll get started. All right, let's go ahead. Thank you for joining me today. Today we'll be talking about end-to-end QA for not just adaptive radiotherapy, but really this is something that can be applied for all your patients. It's QA automation for every patient, every fraction, and helps with every clinical decision that you have along the way. So I'll be talking a lot about some of the new changes that are happening within radiation oncology from a billing perspective, how our patient QA solutions fit into the necessary changes that are going to be coming down the pipe. So during my presentation, I'm going to take myself off my video, but I just wanted to say hi quickly so you can put a face with the voice. But with that, we'll proceed. A little bit more quick introduction about myself. Again, my name is Vicki Howard. I have a master's degree in medical physics as well as an MBA. I'm a product manager and clinical support physicist at Standard Imaging. I did spend over 20 years in the clinic, so I'm very grounded in clinical workflow, pressures that are on physicists, especially these days. I've been out of the clinic for about 5 years, and boy, during those 5 years, it's amazing the changes that have happened in the field. So it's exciting and stressful all at the same time when you're on the clinical side. But I'm happy to be on the product management side so I can help bring solutions to all clinics that will help not just our patients. In the end, that's the ultimate goal, but really clinical data and quality assurance workflows. Bear with me, I'm having an issue with switching slides. I'm going to stop sharing for 1 second. See if this works. Okay, there we go. All right, we got things working. Thank you for being patient. Technology always fails when you don't want it to. Before I jump into the details of our patient QA solutions here at Standard Imaging, I want to take a moment to discuss, as I mentioned, the changes that are or are about to happen in radiation oncology, and discuss how these changes will impact the ways in which we monitor and document quality care for our radiation oncology patients. So first, radiation oncology billing models are changing. There's proposed radiation oncology case rate models that are under review in the Senate now that will shift reimbursement away from per fraction billing towards more bundled disease site payments that emphasize documented quality and medical necessity really across the full course of care. So you're looking at this kind of quality indicators fraction by fraction. This really has a direct implications for how plan changes are approached. Instead of relying on a scheduled boost for our patients or predefined replanning points, daily patient-specific evidence will increasingly determine when and if a new plan is actually needed. This kind of adaptation needs to be triggered by something. So it becomes triggered by really measurable patient change, and that's from a dosimetry perspective. So really in this situation, intent alone is no longer enough. Care must be evidence-driven with clinical decisions supported by very clear kind of chain of proof, meaning you get a meaningful change that's detected, review is justified, and improvement for the patient is confirmed. And so as a result, Every encounter becomes part of the patient's clinical evidence record. You get plan verification, in vivo QA, delivery logs, physician rationale, all of those things together document how each patient was treated and why. And then ultimately, the payment will follow all this patient level data. With this emerging model, every patient, every fraction, and every decision must be defensible. Now, in terms of how things are set up currently for patient QA, we can't accommodate end-to-end patient QA in most cases with what clinics have in place now. So this really does raise the bar for patient-specific QA. It becomes more of a quality-driven reimbursement structure, and this continues to shift toward quality and medical necessity, making the expectations around patient QA be forced to change as well. So it's no longer sufficient to verify a plan once pre-treatment and assume that that remains valid for the patient's course or however many fractions that plan is scheduled. This is especially true as more complex and adaptive treatments become routine. Continuous patient-specific QA really is becoming essential to demonstrate that care is appropriate across the entire course of treatment. So the challenge with traditional patient QA is that traditional QA approaches were not designed for this environment. Device-based measurements, CBCT review, weekly physics QA spot checks are really subjective, they're very labor intensive, and they don't scale with today's clinical complexity. More importantly, they provide very limited visibility into what's actually happening to the patient dosimetrically on a daily basis, making it difficult to detect what they're referring to as meaningful change or justify any changes in the treatment plan. Luckily, guidance, professional guidance is beginning to reflect and evolve to help us prepare for this shift. TG307 recognizes that EPID-based fraction level verification is a practical way to monitor delivery without adding added hardware or resources or time. Additionally, currently in progress, MPPG 20 further reinforces the move towards risk-based patient QA using automation as the foundation. So together, these point towards a new standard for patient QA, where it's continuous, objective, and ultimately focused on clinical impact for every specific patient. So Standard Imaging's patient QA Halo was designed to support this shift, providing gold standard plan verification that sets the stage from the get-go, fraction level monitoring, and automated documentation to enable patient QA to be scalable, risk-based, and end-to-end without adding any workload to the clinic. Patient QA Halo is built on 3 complementary components, IamSure 3D, Adaptivo, and LinAcView, each addressing a critical stage of patient-specific quality assurance. So IamSure 3D begins by establishing confidence before the treatment starts, confidence in your treatment plan. It provides independent 3D dose verification using a gold standard SIMOCA Monte Carlo engine, and its results have been shown to correlate with device-based QA failures. So what this does is it allows clinics to be able to better triage plans in terms of which plans get pre-treatment QA, which plans can go directly to treatment. And it allows you to apply more intensive QA for your complex plans. And this is really important, especially for clinics that maybe will continue to do device-based pre-treatment QA, where it requires a manual setup, after hours physics time, and that kind of scaling as your clinic gets busy or as plans get more complex really can be labor intensive. So if you can have a way to pick and choose which treatment plans you do that deeper dive from a QA perspective, that will really help with workflow and physics load. Now, one way to help alleviate some of this load is to streamline how that pre-treatment QA happens. And that can be done with adaptivo epidosimetry, because that offers both pre-treatment and in vivo QA options. From a pre-treatment QA perspective, using your EPID panel and having the analysis and alerts all automated really helps with your clinical workflow. The therapist can be involved in delivering the plan to the EPID panel, and then from a physics perspective, all that analysis and the documentation is automatically approved, and alerts will let you know if there's something that you need to look into more closely if there's a failure. Otherwise, no news is good news, and it really helps physicists be able to just focus your attention on where there are issues rather than focusing evenly on everybody and not being able to necessarily have time to dive deeper into where there are issues or be more proactive. In terms of in vivo monitoring, it really assists with providing an efficient, objective trigger, and this is the 2D in vivo monitoring. So it provides a daily dose evaluation and potential trigger for when you need to do a more in-depth 3D cone beam CT review or dose review on your cone beam CT for an adaptive plan evaluation. Does this patient need a new plan based on their current anatomy? So this is a very efficient tool that runs automatically in the background. Again, when the patient is delivered, transit epidosimetries are measured and evaluated, and alerts will rise to the surface for the physics team to review. Lastly, we have Linac View, and that closes the loop on delivery QA by analyzing treatment log files at the end of each treatment delivery. And this helps verify MLC, gantry, dose, and timing accuracy, whether that's causing any issues in delivery. And it allows the delivery-related issues to be distinguished from any patient-related dose issues. And that's especially useful for things like online adaptive treatments, where patient is on the table when a replan happens and you can't do any pre-treatment QA. So this is a great way to kind of close the loop on that workflow as well. So the value patient QA halo is really supported by a lot of published evidence at this point and real-world clinical use. So the next few slides, I'm going to go over some of those publications and examples where this data really helped centers find issues that they otherwise wouldn't with their current QA practices. So this slide highlights how I am Sure 3D, which uses the SIMOCA Monte Carlo calculation engine, supports risk-based decision-making for pre-treatment QA. And as I mentioned before, MPPG 20 is really focusing on this type of risk-based QA prioritization. So to do that, you really need something that sets the stage up front. There have been peer-reviewed studies which have validated SIMOCA as a gold standard Monte Carlo dose engine, showing very high agreement with actually QA measurements across IMRT, VMAT, SRS, SBRT, and now for Electa Unity. So it can be easily fit into that workflow as well. And what this does is it's established as a reliable independent reference for plan accuracy. And what it also establishes is that the discrepancies between I am Sure 3D and your treatment planning system matter. The differences between the TPS and SIMOCA have been shown to correlate with device-based QA failures. So these discrepancies consistently flag higher risk scenarios where your treatment planning system models may break down, such as small fields, off-axis targets, and highly modulated plans. The same case is most likely to fail phantom measurements. So what this does is it provides evidence that enables a shift to a risk-based pre-treatment QA. Rather than measuring every plan, Monte Carlo results can be used to target measurements and replanning only when there's data to indicate an elevated risk, while allowing low-risk plans to potentially proceed more confidently without the need for measurement-based pre-treatment QA. Moreover, with calculation times on the order of 1 to 3 minutes for SIMOCA, it works very well in time constraint environments. So again, such as online adaptive workflows where you don't have a chance for physical QA because it's the patient is on the table. This is a way to have a high level of confidence in the new plan that was generated, the new adaptive plan, and any issues that may have surfaced based on pre-treatment QA, device measurements would also surface within your SIMOCA, so you could know where your weaknesses of your plan and potentially replan or shift, change something that makes the plan more deliverable. So the next few slides, I'm going to present some clinical examples as well as research papers showing some of the benefits for each of these the software solutions that make up Patient QA Halo. And I'm going to start with Adaptivo, and we're going to look more closely at the in vivo epidosimetry module. There's a few cases that I'm going to go over. Each kind of presents a different facet of an advantage of Adaptivo. It's very good at detecting, of course, anatomy changes, but it also is extremely good at looking at some issues, potential issues with planning, as well as setup issues during treatment. So the first case is looking at incorrect planning CT or density. What the situation was is there's a spine plan that was created on a phase-based CT, but it was intended to be planned on average intensity projected CT. So that's the patient free breathing. This was not flagged by their pre-treatment QA. We all know pre-treatment QA being done on a phantom or in air, it's not taking density into account. So any issues with density overrides, or in this case, incorrect CT phase being used, doesn't show up in your pre-treatment QA. And unless you have something like in vivo epidosimetry, you're also not going to see that on delivery. All you're looking at is setup and you're beaming on. But in this case, on the first fraction, they did see a consistent area that was underdosed for both of the treatment arcs. And so this prompted the physics team to do a CBCT review. So the next fraction before treatment, they acquired a CBCT image. And what they ended up seeing here became apparent that the CBCT image, which reflected the treatment, was a free breathing image. However, the planning CT was phase-based. So this area inferiorly, which was represented in this profile, you can see here the area of disagreement on the EPID gamma evaluation, was seeing it had a different density in the plan versus the actual treatment. So the plan had a lot more monitored units or dose being deposited here, because you weren't accounting for a different scatter from the lung versus in this case where the diaphragm was moving in and out of the field. Now this planning issue was confirmed and corrected before the next fraction, and this prevented, continued dose error for this patient that would have never been detected, in my opinion. Now the second example here, the therapists were able to detect subtle setup variations that they couldn't detect with imaging alone. So this is a case where the patient was being treated for head and neck. They had a full head and shoulders mask. And when they set up the patient, of course, we all know if you're treating head and necks in your clinic, there's a lot of setup variation here. You have chin tilt, rotation of the neck, you have the shoulders. There's a lot going on. It can be very tricky looking at just a 2D setup image for therapists to really hone in on if there's a setup issue or not. So in this case, they admitted after the first fraction that they were mostly focusing on the chin and the spine, and they didn't pay much attention here to this slight clavicle misalignment. And even looking at that, I think from a physician perspective, they might not get a sense that this is causing a dosimetric error, especially more centrally here. But you can see on the EPID analysis of the two arcs that there is a dose disagreement inferiorly. And Adaptivo successfully flagged this issue. So the next fraction, they were proactive in trying to correct this setup issue. They had to fine tune a little bit, so it took them a few fractions to get it right, but it was giving them that continuous feedback so that they could hone in on the right setup. It even got to the point, even when they got an overall gamma passing rate. There were small areas of disagreement, and the therapist actually got quite anal about the setup and made it so that there was like literally no disagreement. So that kind of continuous feedback is really important to ensure that patient setup is as accurate as can be. And especially in cases like this where the patient is in a full head and neck mask, things like IGRT are not going to catch that kind of setup issue. So having this to complement some of your IGRT technology is very helpful. The third example here is looking at, anatomy change. Sorry. Driving early replanning. So this patient was going through their first course, it was before their scheduled boost, and the trending in the epidosimetry started showing something was changing and shifting within this patient. You could see, looking at dose profiles, that there was a definite shift in the dose that was reaching the EPID panel, which means dose was not being deposited the way they expected within the patient. So upon closer look at the CBCT, it became very apparent that the patient had lost weight, for one, that the lung volume was much larger now. And this was because during the original planning CT, the patient had fluid buildup in the lungs, and that had since cleared. On top of that, there is tumor regression. So things are shifting. The lung is taking up more of the space. So error in there certainly is going to change the dosimetry a lot more from the original plan, which had tumor as well as fluid in the lungs. So this kind of more proactive review allowed the clinicians to make the decision to start this patient's boost early. They then did post-replan EPID monitoring, and that showed that there was a confirmed improvement in the dose delivery. So it's providing the documentation needed to justify a plan evaluation, to dive deeper into the CBCT evaluation, so you know which patients you should spend that extra time on. And then it showed that there was a benefit from the replan. So throughout the whole process, you're able to justify the improved quality from those actions. And lastly, I'm going to talk a little bit about LINAC-View. So LINAC-View is our log file based solution. As I mentioned, it's a great complement to Adaptivo, because if there are deviations in Adaptivo from an epidosimetry perspective, we need to rule out if any of that came from machine performance. And what LINAC-View does is it just looks at the log file base, and it will compare it to what's expected from the plan and provide alerts as necessary if there's anything that's deviated. It provides an overall view of the treatment delivery in terms of an MU-weighted fluence map. But on top of that, you can also dig down if there is an issue and look at MLC-related issues, gantry, timing of the dose delivery, etc. So it allows you to really be able to sort through. And it's a great link between your patient-specific QA and your machine-related QA. So now there are papers out there where it looked at LINAC-View and also compared RT plans generated from LINAC-View and calculated with Monte Carlo-based dose engines, and it compared that back to the treatment planning system result. And what that showed is that LINAC-View RT plans generated from the log files recalculated with Monte Carlo really did provide an accurate patient-specific delivery verification. So one nice thing about being able to generate an RT plan with Linac View is you can do that calculation back in your treatment planning system. You can import that plan in there, and then any differences are truly delivery differences because you're using your same beam model, your same calculation algorithm. They also found out that it's highly sensitive to delivery errors, so they purposely put delivery errors into their plans, and they were able to see that Linac View could detect sub-millimeter MLC deviations that wouldn't be detected by phantom-based pretreatment QA alone. As I mentioned, this is a great complement to EPID in vivo dosimetry. Linac View verifies how the plan was delivered, while Adaptivo captures how anatomy and delivered dose changed for the patient. So this is not only something that you could use as a pre-treatment QA tool along with your pre-treatment EPID dosimetry, but it's something that you can monitor machine performance all throughout the patient's treatment. And again, all this analysis is automatic. As soon as the treatment is complete, it will grab the log file information, do an analysis, and will alert the physicist if there is an issue. So ultimately, this closes the patient QA loop. It allows you to separate your machine-related delivery issues from patient-related dose effects to support clear, defensible clinical decisions. So in the end, Patient QA Halo offers your gold standard plan verification algorithm that allows you to then make downstream risk-based patient QA decisions. So maybe it gives you the confidence to skip pre-treatment QA for some, or might flag some plans that are pushing the limits of your algorithm and perhaps need to be reevaluated in terms of how that plan is generated, or it helps you target which plans specifically need pre-treatment QA attention. Lastly, as you move down the stream, you have Adaptivo, which then brings the patient into the QA. From a daily treatment perspective, you're able to keep an eye on setup issues, anatomy issues, and early on detect whether there are any issues with the treatment plan itself in terms of how that was calculated and does it truly reflect the patient anatomy and density. And then lastly, Linac View, like I said, closes the loop on that and allows you to tie in the treatment delivery every fraction. So you have that end-to-end view and quality metrics for your patients. All right, at that, I'm going to open it up to any questions.
Hi, Vicky, you have one question. Does Linac View work with all Linac vendors?
Linac View works with Varian and Elekta Unity.
Okay. And is Linac View installed on local computers or on the cloud login?
They're local, but they can be accessed within your network.
Those are the two questions we have so far.
Well, if you have any other questions, feel free to reach out at me. My email's right here on the screen, vhoward@standardimaging.com. Or if you want to contact your sales representative, you can be directed by emailing sales@standardimaging.com, and we're happy to help you. I'm also happy to give more in-depth demos of the software themselves. This talk was mostly focused on kind of giving you a broad overview of how QA is shifting in radiation oncology and how our patient QA Halo can help address that shift. All right, at that, I will say goodbye. Thank you very much.